Good evening. President Trump signed an executive. Sorry, I'm going to start again. Good evening. President Trump signed an executive order basically dismantling the Department of Education. Just watch.
My administration will take all lawful steps to shut down the department. We're going to shut it down and shut it down as quickly as possible. It's doing us no good. We want to return our students to the states where just some of the governors here are so happy about this. They want education to come back to them, to come back to the states, and they're going to do a phenomenal job. But we're going to be returning education very simply back to the states where it belongs, and this is a very popular thing to do, but much more importantly, it's a common sense thing to do, and it's going to work. Absolutely, it's going to work. I want to just make one little personal statement. Teachers, to me, are among the most important people in this country, and we're going to take care of our teachers. And I don't care if they're in the union or not in the union. That doesn't matter. But we're going to take care of our teachers, and I believe the states will take actually better care of them than they are taken care of right now.
This action is praised by many and criticized by others. I too initially was conflicted, not because I believed it was the wrong decision. You have to remember the Department of Education was enacted by President Jimmy Carter because of pressure from the teachers' union, not necessarily teachers, but the teachers' union. And since that time, our standards have decreased and children are literally graduating without knowing how to read. Just look at this national report card. Our reading levels are so low. The proficiency of fourth graders, 39% really understand math that is equal to their age group. In reading at 31%, and still bad numbers at grade 8, 28% proficient in math and 30% proficient in reading. It is despicable. We all know that, especially at-risk kids, their salvation is a good education, to be able to get good jobs. If they're growing up in poverty, it shouldn't matter that they don't have opportunity when they graduate from high school, even without a college education, if they can read and write and know the classics. And when I say classic, that's language skills, art, geography, history, mathematics, English proficiency, reading comprehension. Why we failed so much since the Department of Education has been enacted, I am told it's because of the bureaucracy in Washington, D.C. They have a full staff, but really they don't do anything to improve kids' learning. There's nothing new actually coming about. As a matter of fact, it's taken a step backwards. And when they do get a little innovative, it's taking a step backwards, like Common Core, or making the decision not to teach cursive, yet all of our founding fathers' documents are in cursive writing. Sure, they can get it online in regular print, but it is a sad day. But I'll tell you why I was conflicted. The subject of education of our young people has been on my mind for decades. Approximately 8 years or so, people paid to come hear what I thought about education and health at conferences. And I gave this particular lecture at a conference in Chicago, which I'm going to go through with you at an abbreviated rate with you tonight. But I'm conflicted because of some of these radical states. New York, remember? when they voted that city council to kill babies up to 9 months and they celebrated, they put lights all over their building. When Governor Cuomo at the time said it's okay for murderers to be out on the streets, California, who have decreased the penalties for pedophiles, it's like kids have no rights anymore. We don't protect the most vulnerable, which is our young and our elderly and those who are disabled. So that's why I'm concerned. I don't necessarily think it's the wrong decision. I'm concerned about the radicalized states. But even before this, I did this program, and I'll tell you how I think. You've heard me say it before. My mind naturally is a system thinking mind where I never look at anything in isolation vertically. Like, okay, if I change this, that's all I think about. I think about everything, how it's connected. If I change this, blah, blah, blah is also going to happen. Like, I have a full view. My mind naturally does that and would question my employees, the director, people at director level. Well, why are you doing that? Have you thought of this or thought of that? So we were good teams because I was always the one to say, well, what else? Have you thought of this? So I was thinking about our poor education system, and I find myself a child advocate. There's something in me, I think it's from above, that God wants me, and it's just in my DNA to protect children. And some of that's against sex predators, and it's also definitely with health, and also with education. So why don't we combine both? So that's where I start. And I also have a theoretical framework saying there's enough money in the system. We're just spending it in the wrong place, that we can really take care of our citizens. And certainly Elon Musk is finding a lot of that waste that we could have used for better roads, better bridges, better health care, better research, a lot of things. So let's go through these slides together. So the whole premise is healthcare reform, government spending in healthcare. So this is a little dated. Like I said, some of this stuff is from 2019 because the data is always years behind. There could be updated data, and I'm hoping to get that soon. But let's go to the next slide. Healthcare spending and the GDP. At 3.85 trillion seasonally adjusted rate, you got it. National health spending in July of 2019 was 4.3% higher than it was in July 2018. So we continue to show that growth. The July 2019 nominal gross domestic product growth over a 12-month period was 4.2%, and the resulting health spending share of the GDP was 17.9%. We're the United States of America. One would think, oh, we're a healthy country. Well, I know you've all been finding out how unhealthy we actually are. But growth in hospital spending accounts for 33% of national spending. Remember, we have government programs, Medicaid, welfare, and Medicare for our elderly. I am not proposing any cuts, although welfare, I would like to see time limited. I have no problem with helping a neighbor in trouble. My taxpayer dollars, just like I'm sure the same with you. But it can't be generational. It can't be, okay, this whole family's been on welfare their whole life. They're having babies and now they're on welfare. It's going to be time limited. What that time limit is, 1 year, 2 years, I think we can debate about that. We do have to look at that. But having said that, that's not what this is about. And in August of 2019 was the 122nd month of expansion, the longest in U.S. history following the Great Recession. Yet the healthcare price index growth is steady near 1.5%. We'll go to the next slide. I'm not going to get too much in detail about all this because unless you're in the business, it can be a little bit difficult to understand. But look at this graphic kind of says it all. The tax expenditures. So we're spending an awful lot of money on Medicaid and Medicare, and we want to be healthier. So why are we spending so much money? So it's just going in the wrong places. We'll go to the next slide. So again, this is a little dated. This is from 2017. This may be the last updated data we have. I am seeking new data from the government to see how much it's changed. But the federal share, because it's split, the feds contribute so much, the state contributes so much, is estimated to have been 63% in 2017. State Medicaid expenditures are estimated to have increased 4.2% to $221.6 billion. Difficult for the states as well. We're getting sicker. So, needless to say, not getting too much in the weeds, Medicaid spending keeps getting higher and higher. A couple of things I look at, you can go to the next slide. When we look at data, some of it has to be generalized because each region, get this, you're going to love this one, and it's true for Medicare as well, have different NGOs. I know you know that word now. Non-government organizations. So they're third-party contractors who contract with the United States government, usually to do payment systems, right? The government isn't good about paying things and processing a lot of data and information. So these NGOs do the job. But each region has a different NGO, and sometimes they have different decision makers. What may be approved for someone maybe to come into the hospital before surgery because they have a lot of risk factors and they need a lot of prep. One area may say, okay, we'll cover that under Medicare or Medicaid. Another area may deny it. It's kind of crazy. So that is an issue that needs to be rectified. The NGOs should be working under the clearest of expectations, and there needs to be a better way to escalate a problem. There is nothing more frustrating for a patient or a provider who absolutely knows this patient needs a particular course of treatment and have Medicaid or Medicare deny it. CHIP spending. This is a program I actually love. It's really children, and it's an enhanced program for medical expenditures. But again, that keeps rising and rising. And since its inception in 1965, it's just year over year spending a lot of money. Again, when you think we should be getting healthier, the spending should go down a little bit. But our highest risk areas are young people, especially the newborns who need NICU care, neonatal intensive care unit, and the elderly who are often hospitalized for lengthy amount of times. So getting into Medicare spending, which is the next slide. So Medicaid, typically, there are exceptions, is for younger people, not just children. Adults could be on Medicaid. Again, I think that should be very limited, but adults could be on Medicaid, but Medicare is typically for those individuals 65 and and above. So those are increasing. They're expected to continue to increase. As of this slide, which I believe this one was from 2017, we went from 3.7% of the GDP in 2018. Oh, this is a projection to 6.5% in 2093. This is why you hear healthcare professionals always warning policymakers, taxpayers, that the current system is unsustainable in the long run. And I have a solution. I have many solutions. So again, I just go on and we'll look at the next slide, please. And I know this print is very small. Maybe we could make it a little bit bigger, but there's something right up the street from me in my very own state, Dartmouth College, which is an Ivy League college, and they have something called the Dartmouth Atlas. I do believe it can be accessed by anybody, but it has a lot of information, a lot of data. Interpreting it, maybe something different, but the Medicare spending varies more than twofold among hospital referral regions. Spending also varies from state to state and from one hospital to another, even among hospitals within the same region. So what does that mean? That means when I was hospital CEO, I tried really hard to lower prices, which economically didn't seem feasible, right? I was in a rural hospital. So usually when volume is down, you have to raise the prices because the staff, doctors, nurses cost a lot of money. You know, the payroll was in the millions every month. So normally you have to raise prices in a rural area to cover. I couldn't get a pharmacist probably for less than $120,000 a year, and that's right out of school. But I was able to do it through a lot of ingenious things and ways. But anyways, I was able to lower prices. So I'm going to make up these numbers. But say for a CAT scan of your abdomen, I charged $800. But the hospital 20 miles away costs $1,200 there. Why? Definitely in the Dartmouth Atlas, we could see throughout the country big difference. Certainly you could understand in some high price urban cities where everything is more expensive, that prices may be up to not only cover, you have to pay staff even more, although in rural areas you often do to get them to come to the rural area. Even in urban areas, you know, for the cost of housing, you know, staff have to be able to like their job and be paid well to have a house, etc. So there's that variability that needs to be looked at as well. And then we look at the next slide, the national health expenditures by type and payer. This is how much we can break down. We can look at the type of expenditure for hospital care, physician and clinical services, dental services, home health care, public health activity, etc. And we'll go to the next slide. So beginning of life critical care spending. This is what I was talking about. So in 2017, 1 in 10 babies were born premature. That's terrible for an industrialized nation like the United States. And care for infants in NICUs accounts for 75% of all dollars spent on newborn care. Can you believe that? The total economic cost of preterm birth has been estimated, and this is a very low estimation, at $26 billion annually. NICU admissions account for About 1 in every 1,000 members in a commercial healthcare plan. You wonder why your premiums are so much. A lot of it is to cover newborn care. When you look at 75% of all cost, older people and those with chronic disease, who's going to have to pay for that, right? It's sometimes on the back of very healthy people. So this is a stunning, stunning slide in all the information that is right there that we can pinpoint where a lot of healthcare dollars are spent. Why is that important? When we pinpoint it, there should be a revelation, right? Why are so many babies born premature? Is it lack of prenatal care? If it's funding, let's look at that. If it's drug abuse, because remember, this is 2017 statistics, man, oh man, did we see this change in the 5 years post 2017 with babies born addicted to mainly heroin, but of course methamphetamines and other things, but mainly heroin. And the NICU admissions were through the roof. And we're not talking about a week in the NICU. We're talking about months and months of care, trying to basically detoxify these infants and getting them normalized, getting everything stable. And the long-term results of the early addiction is usually not good. The baby will survive, most likely will survive, but will have all kinds of problems. I've followed this one child from those early days in NICU. She's, I believe, 8 now, has verbal communication issues, skeletal issues, sight issues. It's really a very, very sad thing. So to the next slide, just the opposite, end of life. This has been a little controversial. I don't know if you remember back when John McCain was running for president, there was all this stuff that the Republicans wanted death panels, and Sarah Palin, his VP candidate, wanted death panels. It wasn't people wanted death panels. Everybody, scholars, people in healthcare were saying, holy macaroni, we're spending so much on end of life care, which may not make a difference. And I'll give you an example. Somebody is 89, 90, 91 years old, has a lot of health issues. It looks like their life expectancy, no matter what you do, isn't going to be much longer. And you decide to do a total knee surgery or even an open heart surgery when the person may not even survive the surgery. And then you go ahead and do it. You spend thousands upon hundreds of thousands of dollars, and it doesn't change really the longevity outcome. I know it's a thing that you might say, well, what if they live? I know. And when you look at statistic, there are individuals involved, but we do know the big, big dollars early on in life, later in life, and chronic illnesses. So my conclusion, when we go a couple slides down, there are ample health care funding, but spent in the wrong place. You could go ahead to the next slide. There you go. And I truly believe that. And Elon Musk is proving that every day. Is he at $1 trillion or $2 trillion? I mean, what he is alleging, what he is claiming, is that that's how much waste there is. Wouldn't that be lovely? I know we talk a lot about maybe giving the taxpayers a refund check, which I would like. But wouldn't it be nice to fix our roads, do a little better research? Let's figure out how to get America healthy again. Maybe have some of that money go into health and human services, but spent in the right places. So this is a projected budget deficit, and this is from the government's own Congressional Budget Office. And this is the next slide. That large budget deficits over the next 30 years are projected to drive federal debt held by the public to unprecedented levels from 78% of the gross domestic product in 2019, you're going to die, to 144% by 2049. That projection incorporates CBO's central estimates of various factors, such as productivity growth, interest rates on federal debt, and the CBO's analysis indicates that even if values for those factors differed from the agency's projections, debt several decades from now would probably be much higher than it is today. That's why it's so important that we keep moving on in looking how to improve efficiency, making people healthier, but also getting rid of waste. So the next slide does show you the rising Medicare and Medicaid costs and how it's driving deficits. Again, this is a pretty shocking graphic here. As you see, we just jumped up. It seemed like we really went awry in about 2010. And so, yeah, I have a lot to say about that too. So, okay, so gave you some background, some general background, beginning of life, end of life, chronic diseases. Here's something that Robert Kennedy Jr., Elon Musk, President Trump maybe would like to know. And that's the burden of regulatory agencies. Oops, next slide, please. And we can make that full screen. So here's an estimated burden of compliance with regulatory requirements for a typical community hospital. And this was first put together from the American Hospital Associations. So you see that first line, the blue line, hospital COP. That means conditions of participation. So there's all these rules, and in order to comply with those conditions of participation, you need approximately 23 FTEs. That's full-time equivalent. Whatever full-time is for your organization might be 32 hours, 36, 40 hours. And how much upfront IT costs, etc. We're talking about some big dollars, big resources, and it has nothing to do with real patient care. I have no problem ever if there's a regulatory statute for patient safety. That's not what I'm talking about. I'll love that all because I'm going to do it anyway, even if there wasn't a regulation. But I'm not talking about those things that do help a patient or safeguard a patient. These are regulations that don't make a lot of sense. And then when you go down the list there's all kinds of stuff. There's something called meaningful use that was with the Bush administration, pushing everybody to the electronic health record, which, some might say are good or bad, but and it costs a lot of money, right? You need redundancy systems. Some of the laptops you got to replace every 4 years. Big money investment. But if it adds to patient safety, that's good. Because we definitely identified too many people were misinterpreting a provider's signature or orders. So it would be up to the nurse and pharmacist to interpret that. They may or may not get it right or wrong. So now the provider actually has to go into the computer in a hospital and do their own orders. That way there's no misinterpreting their orders. But all of these programs take resources and take money. And let's go to the next slide. So here's and we'll do this full screen. Regulatory burden overwhelming providers, diverting clinicians from patient care. I've seen this through the years. A lot of us old timers say, oh, I yearn for the old days. We were able to be at the bedside so much more. It seemed like we were able to really dive into a patient case, and now we're slave to the computer. So there has to be some balance, but it's estimated that $39 billion was spent by health systems, hospitals, and post-acute care providers each year on non-clinical regulatory requirements. And I'm talking about just hospitals mainly, but can you imagine the sole provider in the community? This is when we've seen a change in private providers. So a nurse practitioner like myself can hang up a shingle and I can see patients all day long. So can a medical doctor do the same thing. But when a lot of these rules and mandates came out, the solo provider, even if you're in a group of 2 or 5 other providers, it was cost prohibitive. So we saw hospitals employing massive amounts of providers. Again, is it a good thing or is it a bad thing? A lot of people think it's a bad thing that we lost independent providers and they're not a slave to the bureaucracy of a hospital. So let's go to the next one. Again, just pointing out just the regulatory burdens. And this is a very interesting one to me because all my career, I was also an executive in a very, very large hospital in Pennsylvania, an executive in a hospital in Tennessee. I always thought about cost to the patient. It really bothered me. And I tried every way to reduce costs. But look at that middle section. Regulatory burden cost, $1,200 every time a patient is admitted to a hospital. So you might not even have had a treatment yet. You may not have even had a nurse come in the room to give you a physical exam upon admission, and already your bill is $1,200. And I'm sure that's higher today. Just look at this next slide. This is a typical hospital in all the federal agencies with regulatory authority impacting your health system, hospitals, and providers. Can you imagine that? Look at all of them. And each, like, I think I counted one time to my last hospital, and there was like 40 or more, 40 to 60, I can't recall exactly, of licensing agencies who could dictate what they need, what they want. Again, I have no problem if that benefits a patient. But if it doesn't, it doesn't. And we got to get rid of it. But here on the next slide, I'm giving you background, end of life, beginning of life, end of life, and chronic disease. I have to tell you, I was impressed with Robert Kennedy because he's a lay person. And although he did have a lot of facts surrounding Fauci in the mRNA vaccine, he wrote a very good book. But he also brought up chronic disease. And that's one thing in the industry we all know about when we see the statistics. But he talks about this, and a lot of it is related to food and what we ingest. We just keep getting fatter and fatter. And because of the type of foods we're ingesting, that it is making us sicker with metabolic diseases. So what are chronic diseases? Well, broadly defined, mental or physical conditions that last 1 year or more and require ongoing medical attention or limit activities of daily living. Chronic diseases such as heart disease, cancer, diabetes are the leading causes of death and disability in the United States. They are also leading drivers of the nation's $3.3 trillion trillion in annual healthcare costs. So let's look at chronic diseases, and that's the next slide. You'll see heart disease, cancer, chronic lung disease, stroke, Alzheimer's disease, diabetes, chronic kidney disease. So 6 in 10 adults in the US have a chronic disease. 4 in 10 adults in the US have 2 or more. And again, we're supposed to be the leading industrialized nation, and we're this sick? Let's go to the next slide. Some of the major risk factors you've been hearing about. Again, thank you, Robert Kennedy, because obviously some of us in healthcare weren't making enough noise or weren't in the right positions or whatever to bring it to a national attention. Poor nutrition. And I talk about this in my education reform packet coming up. Stress is terrible on the body. It's no joke. We have to learn ways of coping. In the last 4 years, we've seen mental health rise dramatically, especially in our young people. Anxiety, social ineptness, depression. Lack of physical activity. Holy macaroni, has our lives changed? As children, you were out playing all the time. You never wanted to come in. Your parents had to force you when the street lights came on. And now it's a solitary type of life our children are leading. If they're not in, team sports, they're home in their room on their iPad, on their iPhone, and they get lost in that. And nobody's moving. Obesity, major problem, so many levels. Heart disease can lead to cancer, can lead to orthopedic issues. It just goes metabolic issues, neurological issues. Excessive alcohol use, another risk factor, and tobacco use. So some of the harmful, next slide, effects of poor nutrition, I don't have to get into much detail. You can go on Rumble and watch a lot of great nutritionalists talk about the harmful effects of poor nutrition and how to eat better. But obviously it affects obesity, heart disease, and stroke, and type 2 diabetes. And I'll tell you a little secret about type 2 diabetes. You may be on sugar pills or even insulin with type 2 diabetes. A lot of times, well, you know what the cure is? Lose weight. Get into your proper BMI, although BMI is, I know, a little controversial. But you would never have gotten type 2 if you weren't obese. Next slide. So again, effects of poor nutrition. And a lack of physical activity is the same thing. So let's move on to the current statistics show that $117 billion in annual healthcare dollars are related to, I think it's 2 slides ahead. There you go. Related to low physical activity. 147 billion on obesity. 9 in 10 Americans consume too much sodium. How about too much sugar? 4 in 5 students in high school do not get enough physical activity. So the other thing that's really, really important to note is your teeth. We talk a lot about health, losing weight, eating the right things, physical activity, and we forget the mouth. And I was very proud. My hospital worked with a federally qualified health center to bring dental care to at-risk communities. And my hospital gave out lots of toothbrushes and toothpaste, teaching young people how to brush their teeth, because we have good and bad bacteria. I think this is a couple slides. There you go. And when the bad bacteria takes over, it could get into your GI system. It can cause a lot of problems. If you have an abscess, that could get into your brain. The bacteria also can get into your lungs. There's long-term effects that research shows that go along with poor dentition. So I'm going to move forward because we're getting to the end of my show. But bending the health outcome curve, a couple slides ahead, we just need to redirect current spending, focus on preventative measures, and reduce cost for the consumer. How do we do it? We haven't been successful in the office, in the hospital. We're treating an illness, then go home. We have to do more prevention. And we've struggled with this, how to really do that. Well, let's do it in school. Let's combine health initiatives with really good school initiatives. Let's expand the school day, right? Let's extend the school year to incorporate some of these health measures. Let's introduce 60 minutes of physical activity in that child's school day. Unless if they're on a soccer team and they have lots of practices, maybe they can opt out. But we need to have health initiatives. But also, as you see in that middle bullet point, we absolutely need to ensure that there's time to elevate educational greatness in language, geography, history, mathematics, science, and reading. Number 2, adding nutritional, healthy eating classes for students of all ages. Even as a young person, you could teach the child that candy bad, candy's only for a holiday, and an apple, a pear is good. So I also, on the third point here, I put that school, because this is my utopia, right? I know that this policy could be debated wildly. When I put out suggestions like this, it's not the end all and beat all. I put it out to spark thinking, and it's a jumping point for better programs. So in my utopian world, the school would provide breakfast and lunch, no matter your ability to pay. That way a child doesn't stick out that their family can afford lunch. So everybody gets a nutritional farm to table food at school. So we can focus on clean foods to energize the child to think and learn. See how systems thinking, one goes with the other. If a child comes into school and their belly aches so bad because they're hungry, they're going to be tired, they can't concentrate, the whole thing. Going to the next slide. Number 4, bringing back self-care, self-reliance courses. I am shocked how young people, my God, I was married young, had my first three babies. I was married by, I had my first 3 babies by 21. We were just so much more advanced. I had great schooling, and you were much more independent at a younger age. But we had these classes in high school, how to sew, how to cook. So teaching financial acumen to young people so they learn how to handle money, debating. We lost that. Children don't know how to debate because young adults don't. Even middle-aged people, we're seeing if they disagree with somebody, they're calling on war to go against them, to bomb a Tesla automotive plant. So we need to do all that. In the next slide, raising the bar. We need to simplify teaching, get to the classics, stay out of social activities, what's called social justice, and push repetitive mathematics, language, and really push those high bars. I put in, we're not going to have enough time, but in my lecture that people paid to come see me to hear about was an eighth grade final exam in Kansas that was done in 1895. You couldn't go into a higher grade. At that time, every grade had a big test that you had to complete before you went to the next grade. And if you were to look at this, you would be shocked. So I think that we can do this. We can take back education to the states. But it's almost like we have to help the teachers get to good school plans because let's face it, we have a percentage of teachers who are activists. They don't really want to teach the children about these higher level skills. They want to, hate to say it, but brainwash your child. Thankfully, that's the exception, not the rule. But hopefully, this helped you in some way. Are you looking for monthly income without the risk of stocks? Here's something you won't hear on CNBC. There's actually a unique way to collect royalties directly from America's most productive oil fields. No exploring, drilling, or operational headaches. You simply collect checks month after month. The best part? You can get started with just $25 through any brokerage account. The Oxford Club's chief income strategist, Mark Lichtenfeld, breaks down what he believes is the #1 oil royalty play for 2025. Visit mariaoilboom.com now to learn more. That's right, mariaoilboom.com. Stop buying oil stocks and start collecting oil royalty checks instead. Welcome back. In our health topic today, we're going to talk with Corinne Lund, who is a nurse who's seeing a lot of adverse reactions to the mRNA injection. You know, I can't call it a vaccine because it doesn't fit the definition of a vaccine. Welcome to the show.
Thank you so much for having me. Thank you.
What kind of setting are you in? Are you in a hospital setting?
I'm in a hospital setting. I work as a float pool nurse and acute care nurse, and I go to all the floors, and often I'm in the house supervisor position. So I see all
You,
and I know all.
yes, and that's so important. I guess once a nurse, always a nurse, but I started out as a nurse and now I'm a medical provider. I'm a nurse practitioner. So I know how important nursing is, and you're the eyes and the ears of the providers all the time because nurses are there 24/7. What are you seeing?
Well, what I'm seeing lately is a really large uptick in heart attacks in patients who are coming in with new onset renal failure. People are getting emergent dialysis catheters placed like almost every week. Before COVID, I would see maybe one or two code STEMIs, which is from heart attacks, per week. Now I'm seeing 2 to 3 a day, and it's the cardiac cath lab is so busy. They're working overtime. It seems like we're constantly seeing people coming in with heart attacks. We also are not seeing so much COVID. We are now seeing something called RSV. They're giving us patients with another thing called a human pneumovirus, which was discovered in 2001. We're seeing a lot of that. People coming in stating that, well, I'm vaccinated against COVID, so it could have been worse. And I'm thinking in my head, well, it could have been a lot better for you, actually. It really breaks my heart to see people getting so sick right now.
I'm wondering if you feel the same way I do. I dedicated my life to healthcare. not only as a provider, but as a hospital CEO, and to have the CDC lie to the American public and cover up a lot of the adverse reactions. Right now, I'm not in the hospital setting, but I would be doing a lot of research probably on our patient data. Is does anybody really want to know the truth? Do you find people are just trying to say, oh, this is just an anomaly, or are they connecting the dots?
I don't think they want to tell the truth. And I do think that coming up with like the RSV, I mean, I never saw that in my whole 20-year career. I never saw so many adults coming into the hospital with RSV. But we're being told, well, that's just the new infection that's coming across this year. Nobody is connecting the dots. And all of these people, all of my patients are vaccinated or they
Mm.
have the mRNA shot.
Yeah.
Some of them have 3 and 4. They got the boosters. And it really breaks my heart. Another thing that I'm seeing that they're, this is a good example of not telling the truth. I have I know somebody who has pericarditis, and the doctor's saying, well, that's a very rare congenital anomaly that you have, rather than telling the patient, this is probably actually related to the mRNA.
Yeah, people weren't even admitting it when athletes were just dropping dead in young people. Certainly,
Right.
there's so much evidence. I've looked at so many studies from Brazil, from Italy. United States were lagging in those studies, but definitely worldwide, they've identified all these adverse reactions. As a matter of fact, and I love independence, the Florida Surgeon General, Dr. Joseph Ladapo, he looked at just his state because he's got that data. If people are covered with, Medicaid, Medicare, he's got the data right in front of him. And he now they don't have a mandate with the mRNA. Even at the time when it was popular, he said absolutely nobody under 40 or 50 can have this because the risk outweighs any benefit you're going to get. He's the only brave one.
Right. And I wish that everybody had followed that. When this vaccine came out, I thought, oh, great, they're trying to help people. But I also told people maybe we shouldn't take this shot. It's too soon. They normally you should have years and years of study before you put out a vaccine. I thought
Mm.
initially they were trying to help people, but now hindsight 2020, I realized this was not to help people. Definitely
Yeah,
not,
and
especially
of
from what I'm
course,
seeing now.
because of the profession we're in, of course we thought they were doing the right thing.
Hmm.
That's normal. I hope you don't beat yourself up on that one. We all just accepted that this was the right way to go. And then when the CDC started covering up information, we know Pfizer did. They fought tooth and nail not to release their clinical studies. They wanted to wait like 75 years. And even in the small amount of time for their clinical studies, you could see the increase in heart attacks and deaths. And now, of course, we're seeing neurological problems. And as you mentioned, kidney problems.
Yes, this is true. And people are coming in every day now with acute respiratory failure. Normal
Mm.
people just cannot tolerate any. It's almost as though their immune systems are shot, and they're coming in with these diseases that are really life threatening.
I talked to a Chinese scientist who now lives in the United States who said that lab, the Wuhan lab, and of course, we have absolute proof they were manipulating the bat virus. I mean, I have the studies, I produced the studies that were done,
Hmm.
they were bragging about it back in 2013. She said it was not an accidental lab leak. She believes it was purposely released. I don't know if we'll ever know whether it was a lab leak or purposely released, or whether we're going to get the truth in this country. I think to start healing and getting trust back in healthcare, we first have to admit our mistakes. And the CDC should be the first one saying, yes, our former director, Rachel Walensky, continued to lie to the American public. She actually said at one point, and it just goes to what you were saying, She said, the people in the hospital are the unvaccinated. I must have called every ICU director I knew and asked, what are you seeing? And they all said, heart attacks, neurological problems, respiratory problems, all vaccinated people. Just as you said.
Yes, it's very sad. It's very heartbreaking, and I want to tell them so much. This is because of your mRNA shot. Please don't take any more.
You know what you're doing, coming out and talking about eyes on, right? This is how we start research, right? We have a theoretical framework, and you're seeing with your eyes, your knowledge, paper right there, these people were vaccinated. And now it's up to us in healthcare to take that further and do some more research. But I appreciate your braveness, and keep fighting for authenticity and transparency in healthcare.
Oh, I will, and I will continue that. I tell them every day, eat good food, get exercise, drink clear water, stay away from any further mRNA shots.
Thank you very
Absolutely.
much for joining me.
Thank you.
Thank you for joining me, and I will see you on Wednesday evening.